Yes, Dr. Bob, you can start.
Can you see? Can you see the lecture?
Yes, very good. Tamam.
Does it appear?
شايفينه دكتورة واضح.
طيب بسم الله الرحمن الرحيم وبه نستعين والصلاة والسلام على أشرف المرسلين سيد الخلق أجمعين وعلى آله وصحبه وسلم. We are going to start our series of lectures and breast imaging, starting by approach to mammography, lecture 1, starting by evolution of technologies from past to recent. As you know, mammography is the first chair in the orchestra of diagnostic breast imaging tool, and it remains the mainstay and gold standard technique, allows the early detection of non-palpable cancer with a sensitivity ranging between 60 to up to 87% and specificity up to 96%. And as you know, it is an X-ray examination of the breast, can be used in diagnostic and screening setting. We can use contrast, inject contrast through the nipple to delineate the ductal system in electrography, and can be used as guidance for biopsy. Mammography saves lives, can be performed in a mobile mammography bus, can be performed in a radiology department press unit, usually performed in a standing position, but can be also performed in a sitting position depending on the patient conditions. And the patient can also leaning or bending forward or even lying prone to use the gravity, pushing or pulling the breast away from the chest wall, and usually it is performed by the technologist and reported by the radiologist. And how can I remove this? Because some of the above of the slides I could not see it. More. Okay. So as you know, the effect of tumor size has a reciprocal relation with the survival, and usually we are aiming to pick the cancer as small as possible to improve the patient survival, and this can be achieved by early detection using a mammography. Here we can compare a large palpable cancer in the left breast in image A to a non-palpable cancer presenting as asymmetry, segmental asymmetry with segmental polymorphic calcification. Another comparative palpable and non-palpable cancer. In this case, here you can see a large palpable high density irregular mass with a lot of reactions in the surrounding mammographic images and intramammary involvement, malignant lymph nodes, compared to this almost nearly normal mammography, except for a small evolving focal asymmetry due to breast cancer, a non-palpable breast cancer. Again, here, this is a large irregular high density mass of a palpable breast cancer. Can you show me the non-palpable cancer in image A? Any volunteer? Is it clear? The cancer, the small non-palpable cancer in image A? Okay, so
this
is a tiny non-palpable cancer
in image 8. So with the use or with the era of screening mammography, it brought about the mainly palpable cancer to be replaced by a non-palpable cancer, and the large number of non-palpable cancer lesions are being detected, and definitely this has significant impact on breast cancer management. This lady, 70-year-old, has right
Listen.
breast cancer.
Listen. ماذا ياسر؟
Excuse me. Would you please close your mic, all of you?
So sorry, Dr. Babas, I have technical problem. Most of the slide hidden. I'm so sorry.
Okay. Can you show me a cancer in this, another cancer in this patient? Can you see any lesion, any suspicious lesion in this patient? No one can see it? Okay.
Yes,
Can
and
you?
وين الصورة؟
Who's talking?
أنا سارة عثمان.
أهلا سارة. You're welcome.
في الصورة A الCC view على right side في زي irregular posterior lesion.
Okay, this is the treated site. Okay, it is not on the treated site. Okay, this was operative or post-treatment changes.
The whole end.
So is it easier now? Is not on the treatment site.
This is a small lesion in the image, right one, posteriorly, a part of the treated side. Very small. How can I?
Where exactly? Posterior where? You can localize. You can mention exactly where. You are talking about this or something different?
Most of the slide is not this.
You are talking about this lesion or about here or where?
Very small lesion on the right breast.
Right? No, it is in the left side.
I mean right image, the left breast, right image.
Left breast. Here?
One, yes, this one. Yeah, this one.
Okay. Yeah. No, it is seen on the MLO. These are, can you see it here? Is it clear in this image? Definitely on ultrasound, these are cancer, but can you see it in this image? What is this image? What does it represent? What is the difference between this and this one?
The spot compression views.
Yes. Spot lagging, it is the same as that one. It is just spot. This is, look for this mammography and look for this mammography. Is it the same?
The second one looks tomosynthesis.
Excellent. Who's talking?
Me, Suhair.
Suhair, you're welcome. Yes, this is a tomosynthesis spot view here. And you can see, look for these focal asymmetries here on tomosynthesis appear as irregular speculated mass seen here on ultrasound, and these about 6 to adjacent 6 and 4 millimeter cancer. Okay. So these are the lesions here on the full field digital mammography, and here in spot tomosynthesis, and here on ultrasound. Okay, so does mammography radiation increase cancer risk? Screening mammography, does it increase the cancer risk? Any idea? Okay. Radiation doses used for screening mammography of both breasts are considered safe. It is very small. It is virtually non-existing or non-existent. It is about the same amount of radiation a woman would get from her natural background surrounding in about 7 weeks. Does not result in an important increase in lifetime attributable risk. And the expert consider it negligible risk is far outweighed by the potential benefit of mammography, and accordingly, the Society of Breast Imaging and the American College of Radiology and National Comprehensive Cancer Network recommend annual screening mammography beginning at the age of 40 years for women at average risk for breast cancer. However, because ionizing radiation carcinogenic, it is desirable that the radiation dose received by the patient is as low as is reasonably achievable, consistent with required image quality. يعني في النهاية we have to commit, يعني we should not repeat the image and do a lot of mammography image for the patients, or to do unnecessarily image within يعني less than 6 months, or repeated the image unnecessarily. We have to follow the regulations and we have to follow the guidelines. Okay, so regarding the evolution of mammography, can you tell me the difference between these two images? Any difference between these two images? It looks the same for you?
On the left side, it looks digital mammography, and on the right side, it is conventional mammogram.
So here, yeah?
Yeah.
Yes, it is. But what is the difference? Yani, why you said this is digital and this is conventional? Why? Yes, you are right, 100%, but why?
Spatial resolution is increasing in this digital and very poor in the conventional.
Yes, the contrast resolution between the two is totally different. This is low contrast image and this is high contrast image. Can you look for this small breast cancer? Can you show it to me, the corresponding lesions on this mammography? Is it clear here? Can you see it?
Retroareolar high density lesion.
Okay, so can you see it in this image? This is the same patient, but different technique. Yes. Can you see it now?
Yes.
It is upper outer.
Yeah, it is prepectoral.
Yes.
It's a prepectoral. That is a lesion here. But even on retrospect, it is difficult to visualize. If we trace these vessels, we can see some opacity here. We can imagine it might be. So can you tell me again the difference between these two? Again, can you see how it is detailed image here? Contrasty. This is good, very good contrast. Okay.
Digital or right, left looks conventional. Digital on the right side of the image.
Yeah, yes. This is good contrast and this is low contrast. Even the contrast resolution and the spatial resolution are much better on the digital image, but what happened? Okay, look here, you can see sharply demarcated skin and you can see the nipple, you can see even the Cooper's ligament, the differentiation between fat and fibroglandular tissue. But can you see these structures here? Definitely no. Okay, again, the same differences between these two images. You can see the skin and nipple and very contrasty image. The parenchyma well visualized, but here definitely very low contrast image. And again, this is the same difference, okay? Same breast, but different techniques, and definitely this is what? This image B is
digital mammogram.
Digital, and this is analog, okay? So what are the difference between the digital and analog? What is the difference between digital and analog or conventional?
The contrast in digital mammogram is higher than in convention in the analog.
What else?
And more details about the internal structure like Cooper ligaments.
Okay, so the fulfilled digital technique, the detectors is a memory card or electronic form. So it allows manipulations, while the detector in conventional is X-ray film or film screens, okay? And after they are taking the film, it needs to be processed. It will take a longer time, while the digital is faster. And while the conventional having a higher radiations than the digital system by 40%. So the digital reduce the radiation dose to the breast, and the digital having higher contrast resolution in compared to the conventional, characterized by a relatively higher spatial resolutions, and the digital system have high quality image, so it facilitates more detailed image and easier detection of breast cancer, especially in young and denser breasts, while the low quality image of conventional reduce the cancer detections. And the digital offers CAT system program aiding the radiologist and also facilitate cross correlations among different modalities, as well as facilitate comparison between the images between current and previous study, and easy stored and no long loss of the film compared to difficult picture archival in conventional images. However, the digital definitely having a high cost compared to much less expensive analog system, because there is no digital detectors, and the repair, it will be also much less costly. But because no more sold or no more available in the market, the analog system, so it is now difficult to find the spare parts. But still, we have private hospitals there are looking to bring analog systems. So it is important to explain these differences, and all of us, we have to be aware between the two systems. Okay, regarding technical challenges, in 1934, look for this very low contrast image, and because of lack of compressions, the thicker part close to the chest wall, you see how it appears very white compared to a relatively thinner anterior breast. However, with this type of low quality image, Can you see here, there is this opacity. It was reported by lec-1 as infiltrative breast cancer and demonstrate a concordant result with pathology at that time. It demonstrates radiologic pathologic correlations. And at that time, they were also used carbon dioxide insufflation technique. Can you see it and can you compare these two images? Here it was easy delineate a mobile fibroadenoma, but it was difficult to surrounding infiltrative cancer here, involving the chest wall as well as the skin, but because it was distressing technique was eventually discontinued. In the evolution of radiographic techniques, can you tell me when it was first introduced, this technique, the X-ray technique of the breast? Do you know the date of the first technique of the radiographic examination of the breast, when it was started? Anybody knows? When it has been started? Okay, the first one discovered by Salomon, Germany, 1913. It was only 18 years after discovery of X-ray by Roentgen. Okay, and at that time he has paper contribution to the pathology in clinical medicine of breast cancer, but his effort was stopped immediately due to outbreak of the First World War. Okay, and in 1927 it was the first attempt of mammography performed in a living persons, and that German surgeon Ott and his mentor Erwin described crucial role in early detection of breast cancer. Stress here on early detection of breast cancer. And at 1932, a paper analyzing the role of radiology in the assessment of breast tumor was published by Walter. Then, 1930, Stafford Warren performed the first mammogram in the United States, and he published his successful applications of preoperative breast radiograph to help predict malignant from benign disease in 119 patients with histopathological correlations or diagnosis. Then these followed by several generations of technical improvement, describe regular appearance of mammography gland and stressed on the need to examine both breasts for comparison. And there was relatively limited successes due to poor quality image. However, optimistic future was predicted in February 1938 when issues of radiology entitled Early Diagnosis of Breast Cancer. Okay, so in late 1930s, radiologists such as Gershon Cohen and Egan continued to support the value of mammography despite these technical challenges. And they published several studies describe variability of normal radiographic appearance of breast. And in 1948, Gershon Cohen was able to demonstrate feasibility of mammography to depict occult breast cancer. Look for occult breast cancer at that time. And 1951, radiologist role was the first researcher focused on the importance of microclassification to discriminate benign from malignant, and their pattern and characteristic on mammography allow detection of up to 50% of non-palpable breast cancer. Another period of evolution in 1960s again described standard direct exposure mammographic technique and was found to be useful for depicting unsuspected cancer, for decreasing the number of mastectomies from benign lesions. And this is the EGAN techniques. Look for the mammography at that time, and he was using general purpose X-ray with lower kilovoltage less than 40. Is a standard technique describe the breast positioning, getting the nipple in profile, avoid over folding and overlapping, and there was no compressions and direct exposure film, so the time of exposure was long, up to 6 seconds, because the film are direct without screen, and definitely the image was low contrast, considered to be suboptimal, non-diagnostic by our modern standard today, and was, however, it was reproducible and transferable to other practice, and even again published one seminal textbook on mammography at that time. This is the first dedicated mammography system unit, introduced in 1965 of French origin. You can compare it with these new machines, and the public awareness of breast cancer took a big step forward after the War II, when breast cancer was recognized as the second leading cause of death at that time, emphasizing the need to obtain better detection of early cancer. However, only at late 60, about 1966, widespread clinical use of mammography as a screening tool started after the study led by the American radiologist and mammography pioneer Philip Strax. So the screening mammography started since the late 1960s. Comparison in advances of radiographic technique of the breast, as we mentioned, 1930s, they start with direct film exposure mammography and very low quality or very low contrast image. And to visualize the posterior thicker breast, you need to overexpose the anterior thinner breast. Going to zero mammography in 1970, improved depiction of the breast tissue, but with the inexpense of higher radiations in a blue paper, no need to light box, and it is the image, it was inverted. But 2 years later, they introduced the screen film mammography, which was significantly advanced evolution at that time, and improved the visualization of the breast, and reduced the radiation exposure, and it was faster also. And this is supported by a dedicated mammography unit with uniform thickness, and further improve when they start to use the grid system to the era of the full field digital mammography, 2000, when going to the era of fulfilled digital mammography at 2000, definitely this was significant improvement in the diagnostic accuracy of the mammography by using electronic detectors, and definitely reduce the radiation exposure to the breast, improve visualizations, and picking of the cancer. However, is still, as we know, limited by the high density. And can you tell me what does indicate this image? What you can see here in this image? What does it represent?
Ductography.
Ductography.
Showing what? What is abnormality?
Ductography.
What is abnormality in ductography? Is it normal or abnormal?
Filling defect.
Abnormal. Irregularity.
Yes, there is a filling defect here,
Mm.
but it is a smooth filling defect without significant dilatation of the duct. This more than 10 years performed by myself, you see, and here we can measure the length and caliber of this lesion, and ductectomy had been done and pathology was a papilloma. And as you know, here you can see the needle, so we can just inject contrast through a discharging orifice in the nipple to dilate the ductal system, and you can compare it with these suspicious features with dilated proximal dilatation of the duct due to irregular filling defects here. You see, extending even beyond the walls and distal to which the duct is demonstrated beaded appearance in suspicious findings. Here we can see two images of ductogram, one definitely all because of low contrast image. Since 1939, when mammography introduced at that time, but with direct film exposures, you see? And here we can see the contrast, delineate the ductal system, which demonstrates some dilatations and communicating cyst at the center of the breast. You can compare it with the very high resolution, excellent image at current times. And also at that time, they were used a thorough as a contrast for ductography, but was discontinued because of its inflammatory effect and recognition of danger of radiations. And what you can see here, this is a stereotactic biopsy. So in the evolution of mammography, after using ultrasound and MRI as complementary to mammography, you see at 1967, they introduced fine needle aspiration with the stereotactic guidance, and preoperative mammographic localization initially was performed at 1985 before starting use ultrasound as guidance for biopsy. So mammography can be used or can assist for a needle core biopsy and wire localization for pre-surgical assistant. And here you can see this is the wire, and this is the wire in the space at the center of the specimen. And here this is the specimen demonstrate contain calcifications. Okay, so regarding the mammographic performance, as you know, it is the primary breast imaging modality with a sensitivity ranging from 62 to 70 to the 87%, and specificity up to 69%, and positive predictive value up to 55%. Mammography is the only breast imaging modality proof mortality reduction from breast cancer by up to 50%. That is why considered as appropriate screening modality as a primary screening tool. Regarding limitation, as you know, the major limitation of mammography is breast density. And in a recent study of digital mammography demonstrated reduction of sensitivity with increased density, they found sensitivity can be up to 100% in a fatty breast, but can be as low as 50% in a high density or extremely dense breast, while almost fatty breasts was almost all cancer can be visible in a fatty breast. Only half of cancer can be seen in extremely dense breast, and it is not only obscure underlying cancer, also it is an independent risk, moderate risk of breast cancer, the high density. And in spite of improved technology of fulfilled digital mammography, is still suffer from intrinsic tissue overlapping. Further limitations of mammography is incomplete coverage. Sometimes part of the breast might not be included in the field of view, can result in missing of lesions or breast cancer, and severe compression can cause some discomfort for the patient, as well as compression might result in implant prosthesis damage, as well. Interpretation in somewhat is subjective and can result in missing of breast cancer. It does not differentiate between liquid and solid. As you know, the cyst and soft tissue appear as opaque lesions on mammography, and there is some overlap in benign and malignant abnormality, as in case of circumscribed cancers. And as you know, lobular carcinoma by nature is difficult to show itself on mammography most of the time, and definitely using of ionizing radiation in a radiosensitive tissue like breast is one of the limitations of mammography. Some of these limitations can be overcome by using artificial intelligence and deep learning, computer assisted detected tools, which is not affected by tissue density and approved by FDA in 1998. And using computer software, you can pick asymmetry, mass, or calcification. These highlight areas of potential concern to be re-evaluated by radiologists to make the final decision. So the CAT system does not diagnose, but it helps the radiologist as double checks or double reading, you see, to avoid all possible oversights, especially in a dense breast. Can you show me what is the difference between these images?
The first one at the left side is conventional or annual mammogram. The second in the middle is digital mammogram, and the second one is the third one representing tomosynthesis.
Excellent. So this is analog, this is digital, and this is tomosynthesis for the same patient having same lesions. And the difference between these,
on the left side is digital mammogram, and on the right side is the analog.
this is analog. Look for the skin. Can you see? Look for the skin.
This is
الانالوج السكين ما بيظهر.
Can you
This is
see? Can you
tomosynthesis.
see more detail? Look for the Cooper ligaments.
Super ligaments more.
Look for these Cooper ligaments. Look for the skin. What is this? Can you see the image? Is it an analog?
No.
No, this is tomosynthesis.
So analog, it has to be of lower quality image compared to the digital. Which one is better quality image between these two images?
Right.
So definitely is not something better than full digital mammography. So what could it be? Can you see this?
Tomosynthesis?
Can you see this? Can you
Ah,
see
the
this?
contrast enhanced mammography.
No. Can you see here? I can see faintly, I could see something here. But here it is so sharply demarcated. So I'm
Yes,
dealing with
tomosynthesis.
tomosynthesis. Yes. Look for this. This is tomosynthesis, this 2D. So what is the clinical significance of this tomosynthesis? It demonstrates what? So it
Ducts.
gives better sensitivity, improve ability to localize lesion. Look for this lesion. Can you see it here?
Faint.
No. Yani how it shows itself, the visualization of the lesion is
Yeah,
much
yeah,
better. You
Mm.
see, in tomosynthesis.
Tomosynthesis,
Improve
yeah.
the ability to localize the lesion within the breast and to be visualized. Again, what is the difference here? Now, I think it will be more clear. This image is what and this image?
Digital and tomosensitive.
Digital and tomosynthesis. Can you see here? We can see added density here. But can you see it here? Clearly, this is a mass. There is a mass having a convex border and circumscribed, partially circumscribed borders. You see? So again, the tomosynthesis give more appreciable lesion visualization and improve pointing the lesion margins. The difference between these. The left one is
Digital.
yes, 2D. Okay, and this one is
Tomosensitive.
tomosynthesis. Yes, look, this is tomosynthesis. Look for this, and what is the difference in these lesions?
More demarcation of lesion.
Yes, more characterization. Here I could
yes.
see the lesion, but here I could see more the margins of the lesion. Look for the spicules. Look for these
Yes.
long spicules, the margin of the lesion, further characterizations, better delineation and characterization of the lesion. So better detection of small cancer. And definitely here, again,
It's obvious, yeah.
here very clear. Can you see any lesion here, even on retrospect? On retrospect, I can imagine that might be the lesion.
The lesion, yes.
For the mass here and surrounding architectural distortion, look for the mass and the surrounding architectural distortion, and on 2D and on 3D mammogram. So definitely it improves cancer detection. Tomosynthesis improve cancer detections, relatively, especially in relatively dense breast. In relatively dense breast, you see, it improved the cancer detection over, it have a better sensitivity than full digital mammography. So it allow early detection of a small cancer that can be hidden on conventional, relatively dense breast. Again, same things. Can you see here? There is asymmetry. Okay. Here we can see just an asymmetry. But if you can see here, definitely we have
The lesion, irregular
speculate.
lesion with
We
calcification.
have speculated mass with calcification.
Yeah.
So again, improve cancer detections. Again, can you see an abnormality here? Can you see the abnormality in this image?
Prepectoral?
Here you mean?
Yeah.
Let me show you the tomosynthesis. Can you see the lesion here?
Yeah, it is. Yeah, yeah.
This is the location.
Yeah.
Even on retrospect, it's really difficult to see this speculated mass with long spicules and surrounding architectural distortions. You see, and even here there is some
Traction.
retraction. So definitely in this type of heterogeneously dense breast or slightly dense breast, the tomosynthesis is more sensitive than fulfilled digital mammography, pointing the lesion itself, picking the lesions and pointing its margin, its shape, its size, and its exact locations of breast abnormality. Again, it gives better characterization. Here we can see just some architectural distortion, but within these architectural distortion, definitely there are small speculated masses. So it enhances visualization as well as characterization of breast abnormality. Visualization, the sensitivity, characterization, the specificity. So it improves both sensitivity and specificity of, can you see here the abnormality in this image?
Prepectoral region.
In which image?
Digital.
Okay.
I can see in the digital, in the left one.
So on tomosynthesis, where is it on tomosynthesis?
At the same area.
Is it persistent or fade away?
Slightly fade away.
It's fade
Slightly
away.
fade away.
So what does it mean?
Yes.
What does it mean?
It's not true lesion.
Yes, this is superimposed parenchyma.
Okay.
Here you have seen there,
Mm.
see here, this, because it is real, it give more, it become more visualized and more characterized, but here it become less. So definitely this is not a true lesions, this is superimposed parenchyma. So it's
Okay.
also improve specificity of the digital of digital mammography, and therefore it will reduce the recall. The false positive result will decrease and the recall will be decreased. So by looking for the 2D and 3D, here again, this is the same patients. Again, the lesion is really, really very appreciable, showing itself. But here it disappears. Why? Why it shows itself on tomosynthesis, but not on the 2D image? Can you tell me why? We can see this here. This is a 2D image like a closed book. You see? We can see, if we would like to see anything inside this book, like this one, we can see it through the cover of the book. And look for the page, these all paper are stacked over each other. So this is the intrinsic tissue overlapping. While on 3D, you see taking thin slices of the breast, as if we open the book looking for the lesion from at which exact paper within the book. As you have seen here, look, this is slide 36, slide 40, 43. You can see the lesion here is sharply demarcated as 43 image or slides. So the tomosynthesis modified mammographic technique that overcomes some of the limitation of the 2D image, eliminating the effect of overlapping tissue that improve localization of the lesion and characterization of the abnormality within the breast. Again, the same thing. In this 2D image, I'm looking for something inside between these stacked papers covered by the coverage, the book coverage. It is to see normality. But when I open the book, looking inside, okay, looking inside the books, can you see here? Open paper by paper. So I could appreciate at slide 30, this is small cancer. Can you see it here? Definitely no. You see, this is the tomosynthesis. So it overcome the intrinsic tissue overlapping. And the breast tomosynthesis, it's also called a 3D mammography, digital breast tomosynthesis. It advanced technique acquired as multiple low-dose mammographic images from different angles and reconstructed or sensitized into 3D image sets. In this 3D image is similar to the CT, in which series of thin slices are assembled together to create a 3D reconstructions of the body. Okay, but the difference from the CT is that the angles, the sweep angle is smaller. And this is an illustration can demonstrate the breast here between the compression paddles and the detectors. And here you can see the X-ray coming from different angles. That is why it is different from the 2D in giving depth informations. And again, because from different angles, taking an X-ray, okay, allow volumetric reconstructions of the whole breast. And in this, apparently 2D or two-dimensional projections, it is similar to the what we call it, maximum intensity projections. Okay, these images here, these are slices of 3D mammography or tomosynthesis. Okay, again, these images can be reprocessed into a 2D, what is called a sensitized 2D mammography. This one, look at it, it looks like the maximum intensity projections, and it represents the acquired 2D mammography. And why they have done this? To replace the 2D acquired mammography, the aim of which is to reduce the radiation dose. Instead of acquiring 2D as well as 3D, from taking acquired only a 3D, and from a 3D, they are resensitized, okay, a 2D. And by this procedure, they can reduce the overall radiation dose to approximately half dose. And at the same time, the outcome of this synthetic mammogram improve the detection of breast cancer and recall rates, okay, compared to the tomosynthesis along with acquired mammography. Okay, this is 3D or tomosynthesis, and this is sensitized mammogram. Can you see the image? You see, it has a good image comparable to the tomosynthesis. And this is examples of a tomosynthesis, a synthetic mammogram, and this is acquired 2D mammography. This is a lobular carcinoma. You can compare the lesions between the three, and definitely the synthetic image giving an excellent image of that lesions. Look for this. Here we can see subtle area of architectural distortion, and definitely here the architectural distortion seen on tomosynthesis as well as speculated mass with distortion. So tomosynthesis has a higher sensitivity for architectural distortion. This is sub-centimeter mass, 8 millimeter mass only. And this, in this case, the architectural distortion was only visible on tomosynthesis. This is again an image of tomosynthesis. We can see here what? This is the 2D and this is the tomosynthesis. We can see clearer images of the lesions and much pointing of the lesion size than on the 2D, giving almost double size what was seen on the mammography. So it's helpful also in pointing the actual size of the lesions. And this is the tomosynthesis, this patient having cancer in the right breast. Also the tomosynthesis shows this is small lesions, was also shown on MRI and was proven to be a smaller cancer in contralateral breast. So the diagnostic performance of tomosynthesis compared to the digital mammography, which is a newly developing or evolving technology, can be used both in screening and diagnostic setting, has a better sensitivity and specificity compared to full digital mammography, and has a higher sensitivity for architectural distortion, allow increased diagnosis of invasive breast cancer, particularly improve visibility of invasive lobular carcinoma, the area of challenging, and is superior in accuracy, has superior accuracy than fulfilled digital mammography in relatively dense than fatty breast. And earlier detection of node-negative small breast cancer, greater likelihood of detecting multiple additional breast cancer, improve also detection of breast cancer by up to 53%. At the same moment, it decreased likelihood of false positive result and overdiagnosis, improving recall rate by up to 37%, and definitely will reduce unnecessarily biopsy and additional tests. And this, by this, can show improved overall screening performance compared to the fulfilled digital mammography, and increase positive predictive value, improving diagnostic confidence, and also has streamlined the diagnostic workflow and minimized the need for short-term follow-up examination. This will result in redistributing much need time resources for screening. Like other techniques having a limitations, which include more time needed to interpret tomosynthesis, however, now overcome by using artificial intelligence, computer-aided tools, and tomosynthesis benefits are minimal in extremely dense breast and also minimal in a fatty breast. So it is useful in heterogeneous or over just slightly denser breast, not in extremely dense breast or nor in a fatty breast. And tomosynthesis allow detection of more invasive cancer than fulfilled digital mammography. However, its incremental yield is lower than that of ultrasound and MRI. Current understanding of biological profile of tomosynthesis detected cancer is still limited, and whether tomosynthesis improve cancer-specific mortality remain a key questions that require further investigations. The American College of Radiology appropriate criteria similarly recommend either fulfilled digital mammography or tomosynthesis as appropriate for routine screening. And limitation of relative increasing radiation, as we said, overcome by using synthetic mammogram, which reduce the radiation dose to approximately half while maintaining the clinical benefit. Okay. Do you like to continue? Huh?
Yes, we can.
Okay, let us go. Can you show me the difference between these images?
The differentiation of the lesion.
Is it the same? It is the same image. These three images. Do you
Yes, the
think
same.
are
Yes, the
Huh?
same patient. The same patient.
same patient, but it is the same technique? I'm asking about technique. Is it the same technique? Mhm.
On the right is 3D.
The left.
This one,
No.
That one.
No.
Left.
This one. Yes.
this one.
Yes.
Tomo, yes.
Mhm. And this one. And this one.
This is digital.
This is digital. Huh? What is difference? Try to look يعني
More tissue
carefully
characterization.
between
Tissue characterization is more, the lesion more clear in the last image.
and the image in the middle.
The image in the middle, the lesion, it is not clear, but the resolution and is more than the first image.
Yes. So look
Digital
here.
also.
Look for the more details.
The second is
In
digital.
the middle image is a digital,
Is digital.
and in the image in the left
What is the difference? What
uh,
is difference between this and this type?
Here in the last image, tissue lesion is more well demarcated, but tissue
Only
characterization
the
is less.
lesion? Huh?
Part of the lesions, yes, and the tissue characterization is
What about the resolution?
resolution. It is less than the another one.
Where is the parenchyma here?
No parenchyma.
no breast
No
tissue,
parenchyma.
no breast parenchyma is
Okay,
seen
so
in the
why?
right.
Breast
Why there is
resolution.
no parenchyma?
Subtraction.
So here is
Here
subtracting.
the subtraction.
Digital subtraction.
So this is fulfilled digital mammography, and this
طيب.
one,
لا قولي.
tomosynthesis. Okay,
This is Tomo.
this is tomo, and this one where the lesions becoming more dense and there is subtraction of the parenchyma. So what do you expect to be?
Contrast
Contrast.
mammogram.
This is contrast mammography.
Okay.
Okay, so as you know, look here. This is straight arrow, straight arrow, straight arrow. So this is the fulfilled digital mammography demonstrate this speculated mass, which better visualized in tomosynthesis, same mass, and taking somewhat contrast on the contrast mammography. However, contrast mammography demonstrate more intensely enhancing mass, even on retrospect, neither on tomosynthesis nor on 2D image could not be appreciable. So both 2D and 3D or tomosynthesis and fulfilled digital mammography are pivotal in the cancer screening and in the assessment of symptomatic patient. However, both of which they have limited accuracy in a dense breast. Still having, as we mentioned, the tomosynthesis is superior to fulfilled digital mammography in slightly dense breast, not in extremely dense breast. It has limited benefit in extremely dense breast. But here, the contrast mammography is more useful. So, can you tell me the difference or what you have seen in this image? What is going on in this image? Mhm. If you don't know, tell me you don't know. I will pass it. Because to save time.
The left is analog.
Both the same. This is the same.
Both
Yani
are the
this is
same.
MLO and
Okay.
this is view of the same
dense
patient.
breast, dense breast,
Same breast, yes.
dense
Demonstrate
breast.
what?
Difficult to demonstrate the lesion because
Dense
dense
breast.
breast.
Dense
Yeah.
breast. Can you see? This is magnifications. Can you see what is inside the breast?
There is small lesions in the
Uh-huh.
right breast.
Only the
This
right.
one. Multiple,
Bilateral,
multiple.
bilateral round.
Describe this.
Hypodense.
Mainly in the
Okay, describe these lesions. What are these lesions?
Multiple bilateral breast lesion, dense breast,
Multiple bilateral what?
Radiolucent
dense,
with
Yes, lucent lesions.
Radiolucent lesion.
Where exactly?
في الميديال
This is
quadrant.
still
This one. Numerous.
Oh, yes.
Innumerable. These. And even here. What does it mean? Here. Mhm. What does it mean? You have seen it even here, I can say within the breast parenchyma. But when I have seen outside the breast parenchyma, that means
skin lesions. Skin
the
lesions.
skin lesions.
if you look here, some are
Calcified.
Calcification. Having
Right.
calcification.
like calcification.
okay. So what does it mean? What are these?
Cyst,
What type
No,
of
no,
cyst?
no, no, no.
oil
Yes,
cyst,
what type of cyst?
Oily cyst. Yeah,
oil
yeah.
cyst.
Oily cyst.
This is an oil cyst.
Yeah,
This is
yeah.
do the screening
Yes,
mammography,
yes.
and this is oil cyst, and numerous oil cyst. What is
Yes.
called steatocytoma multiplex. Okay, are multiple calcified and non-calcified oil cysts in a sweat gland of the skin. And what about this?
What
about
what we call it what?
steatocytoma multiplex? I brought this image because it simulates this image, just to differentiate.
This is hyperdense, multiple.
Let me know first, what is this image and what is this image? Is it the same here? Here, look, this is screening mammography, same breasts, or MLO and but tell me.
The right side contrast enhanced mammogram.
Yes, yeah. This is, which one is contrast?
The right one, contrast enhanced mammogram.
Yes, Yalla, let me know what is going on. So what do you have here? Yes, this is contrast enhanced.
Multiple bilateral, circumscribed, hyperdense, breast masses, not enhancing at contrast mammogram.
Excellent.
In ultrasound, it shows anechoic lesion with posterior acoustic enhancement, likely representing simple cyst, multiple bilateral simple cyst. But there is comment about one lesion.
What is the clinical significance of contrast enhanced mammography in this case? Yes, it is are not enhanced, are negative. Negative, yes, yeah, because on ultrasound, some demonstrate internal apparent soft tissue as if it is complex.
Internal echoes.
Yeah, as if it is complex cyst. Based on ultrasound, we don't know if these are soft tissue or just tumefactive debris. But based on contrast study, so these inside the cyst are not soft tissue, are not enhancing. So it helps in that way. Okay, so this assist in assessment of inconclusive finding is a problem solving. You see, the cysts are well-defined masses no or negative enhancement. But if we go back, as we mentioned before, one of the limitations of mammography, it cannot differentiate between cyst or soft tissue. We don't know these masses are cyst or fibroadenomas, for example, or whatever the mass is. Okay. And what you can see here, what is this image?
Digital mammography and contrast enhancement.
Okay. Suggestion. Which one contrast enhancement? Which one digital mammography?
On the right side, digital. On the left side is contrast enhancement, lesion more characterization, and wall enhancement.
Okay, there is wall enhancement, I agree. But any other suggestion?
This is MRI. MRI.
Who said MRI?
Yes, it's MRI.
Who said
Contrast. MR press with contrast.
Tasneem or whom is talking?
Yes, it's me, Dr. Tasneem, yes.
Yes, you are welcome, Tasneem. Which one is MRI?
The right image.
one.
The right image.
The right image is digital MRI, excellent. And the left one?
It's contrast.
Contrast enhancement.
This is
Contrast enhancement.
And this is
Yes.
for the same patients. Look at this, for the same patients.
Yes.
Because the orientation definitely in the two exams, this is a patient yani standing up, okay, holding the breast up, pulling, and this is the patient in prone position. You will not see it exactly the same, the sagittal, the MLO and the sagittal MRI, but more or less this is the same. Okay, demonstrate what? Demonstrate what? What
Reference.
Thin wall negative enhancing represent what?
Virus 2.
No, these thin wall negative enhance represent
Cyst.
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 This thin wall cyst, but this is relatively
Thick
enhancing wall.
enhancing wall.
enhancing. Yes.
Thick
So
enhancing wall.
this is on MRI. Sometimes we look at the other characters, but based on just contrast enhanced mammography, because we'll see it in low energy image as opaque, we will not be sure if it is soft tissue or cyst. Without correlate with ultrasound, it will be difficult to evaluate or to comment on ring enhancement. Okay, so this is the whole energy, recombined image contrast study, and this is sagittal, and this is inflamed cyst. You know the inflammatory cyst? Sometimes the inflammatory cyst demonstrate ring enhancement, but usually the ring enhancement for the inflammatory cyst is different, relatively different from that suspicious of cancer based on MRI. And this image, here we can see, this is mammogram, demonstrate architectural
lesion.
and apparent speculated mass.
Yes.
And this image is, here, you can see that when you could not see the parenchyma,
2D image.
You have subtraction.
Subtraction. You see, you cannot see the parenchyma. That means, and you can see opaque. This is the mass here. It appears as opaque. So,
yes,
it represents what? Take up of contrast, take up of iodine contrast.
Yes, 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 yes.
So this is contrast mammography. So this is the digital mammogram,
Digital mammo.
and this is contrast
Contrast.
mammogram.
Mm.
Right? Demonstrate the mass taking diabetes. It enhance. The difference here. Let us go a little bit quick because still we have a lot. What is this? There is arrow.
Last one is
This is
MRI.
Okay, definitely this sagittal MRI demonstrate enhancing mass, cytogeneously enhancing mass, and this one.
Subtraction.
Subtraction.
Then you cannot see the parenchyma. So
Yeah.
this is recombined contrast image demonstrate enhancing mass, and this one
Digital.
digital mammography demonstrate asymmetry here.
Mm,
So
yes.
okay, so this is infiltrating ductal carcinoma. It will be easy overlooked here, definitely, unless it will be palpable. But you can see it here enhanced and definitely will appreciate it on MRI. So what is the contrast enhanced mammography? What is contrast enhanced mammography?
That we use high high technique. No, what do we call? It's a dual energy actually with high and low. So this high and low make a subtraction for the image.
Excellent, excellent, excellent. So first of all, there are many interchangeable names for this technique. It can be, it is contrast enhanced mammography. It's contrast enhanced double energy digital mammography. It is contrast enhanced spectral mammography. It is contrast enhanced digital mammography. If you hear any of these, it means the same technique. This is at the beginning. And it is an emerging complementary breast imaging modality for workup and management of breast cancer. It is combined digital mammography along with an administrations of intravenous contrast for visualization of breast new vascularity in a fashion similar and comparable to MRI. It consists of low and high energy images, digital mammography after administration of iodinated contrast material, and is based on digital subtraction between the two images, one image containing information about breast vascularization, the other one about morphology. So can you tell me the difference between these images after these informations? What is this image? It will represent what? Regarding enhanced mammography, contrast enhanced mammography. This it will represent. It looks like regular mammography. So what do you think?
Mammography. Subtraction, middle one, and contrast enhancing last one.
Okay, we said we have two images. We have low energy and high energy. Which one is low energy and which one is high energy? Usually mammography, doing mammography with
low energy.
Low energy. So you expect this to be
low energy.
Low energy image. And this one?
High energy.
High energy.
High energy. And this one?
Subtraction.
Excellent. Post-processing or recombined. This low energy, high energy, okay? Low energy, high energy, and enhanced double energy. And usually the high energy is non-interpretable. You see, the interpretable one is the combined or post-processed. Okay, so a contrast, what is the imaging protocol acquisitions. For the contrast enhanced, there is no optimal imaging protocol like on MRI, but generally there is accepted guidelines exist. Okay, and they are using about 300 to 370 milligram per mil low osmolarity iodine-based contrast material and injected before image acquisition. Do you think why? Why they inject contrast before image acquisition? There is a gap. Yani, why they have a gap of about 2 minutes before taking the
For an enhancement.
Okay, so the total volume is 1.5 mil per kg of body weight, maximum 150 mil, at a rate of 3 mil per second, preferably use injector and saline flush. Again, image acquisition begin 2 to 2.5 minutes after contrast injection. Why? In breast image acquisition taking after what we are doing, what to do mammography. Compression. And what will happen if we compress the breast? What about the contrast?
The contrast will not go easy, so that we need time.
Yes. So if we will do it immediately, we might avoid, we give this time to avoid occlusion of small vessels and to allow adequate uptake by the small breast cancer. Okay, so as not to prevent the passage of contrast to in a small new vascularity of small cancers, and it might give a false negative results. So we are doing standard CC and MLO of each breast as dual energy technique. Low energy, as you know, between 25 to 34 kVb below the K edge of iodine. So in low energy image, no contrast is seen. While the high energy image, usually 45 to 49 kVb, so above the K edge of the iodine, and the high energy image will reveal contrast, but it is non-interpretable. So the low energy and high energy then are automatically processed to result a recombined image, which the interpretable or demonstrate or highlight the contrast enhancement because they remove background or subtract background parenchyma. So some radiologists prefer to start by symptomatic breast, but there is no scientific evidence support this approach, and preferably to do it in the same order as mammography. And the image should be obtained in quick successions and preferably to be within 6 minutes maximum. And as contrast, it remains for 10 minutes. So it is enough time for additional views like drawing and any additional diagnostic imaging should be taken after completions of the standard view. And this additional view can be performed with or without dual energy technique. Here we can see how it can be done or it can be performed. Here you see the contrast injected intravenously with a lag of 2 to 2.5 minutes. Then put a compression, okay, taking this image here in this image of left breast, for example, taking both with the same compression, take the low energy and high energy below, and then remove the compression, go to the other side, do the MLO, low and high energy. Release the compression. Go back to the contralateral breast, taking the CC view, low and high. Release the compression. Go back to the other breast, do low and high. So with the same compression, take both the low and high energy, try to make it as very quick, as we mentioned. And the images are considered to be diagnostic value if they are acquired within 10 minutes. Is it clear? Clear, yeah?
You can again just
Huh?
Yeah, clear.
say it again.
Okay, so we said give the contrast. For example, starting by the right, give the contrast. Go to the right side. After 2 minutes, put the compression. Take low energy and high energy. Release the right. Go to the left. Do the compression. Take low energy and high energy. Okay? MLO, MLO. Finish MLO. Go back to the right. Do the CC view. Low and high. Release. Go back to the left. Put the compression. Do the CC, low and high energy. As quick as possible. Within 5 to 6 minutes. Maximum, it has to be within 10 minutes. If it exceeds the 10 minutes, it will not be of diagnostic value because the contrast, it will be gone. Is it clear? So we will be ended with low energy image and high energy image. So these two image, acquired image, low and high energy. Sorry. Then, sorry. What happening here? Okay. Stuck. Let's stuck. Go back. Sorry. Okay. Here, it should not come immediately. But here we have low and high. When these are automatically processed, will result in recombined image that highlight the area of enhancement. And we don't need this high energy image. So it will be removed. So we have to be the study to include the low energy and recombined energy. 2 image for bare breast, bare view. For MLO, right MLO, you have 2 image. Right CC, you have 2 image. Left CC, you have 2 image. Left MLO, you have 2 image. And at the end, will be ended with low energy and recombined images. These for the radiologist for reporting. Is it clear here?
Yes.
You are following?
Yes.
Again, the acquired image is low energy and high energy image. These are the acquired image. Automatically, these are reprocessed to result in a recombined image which highlight the contrast. We don't like the high energy, non-interpretable this one. So it has to be disappear. At the end, we have what? We have MLO, okay? 2 image for MLO for each breast. 2 image for CC view for each breast. So for the radiologist provided with 2 image per breast, per view. And at the end, we have low energy and recombined images for diagnostic evaluation. Is it clear?
Yes.
I think
Yes.
will be clear. Okay. So here, this is the low energy. It serves as a standard digital mammogram, and reporting for the should be the same as mammography. Sorry, I don't know what's happening here. There is some change. Okay. Type. Okay. So this is, as we mentioned, this is like, it serves like mammography, and this is served like what? It's similar to MRI because it demonstrates enhancing image, okay? And contrast enhancement has advantages in demonstrating both morphology or anatomy along with, okay, contrast or angiogenesis effect. And the significant findings on contrast enhancement, it could be in this image or in this image or both. Yes? And overall description should be included. And because it is a new technique, still there is no BI-RAD lexicon for interpretation of contrast study. Okay? But the ACR are still working on it and expected to be in the next edition to appear a lexicons for the contrast study. However, they recommend to report low energy image using BI-RAD of mammography. Okay, because it is same as mammography, it's same as regular mammography, and to report the recombined image using the BI-RAD lexicons of MRI. But here, it is not exactly as MRI. It is not a dynamic study. So we are not using the kinetics curve of mammography, is not applicable in this case. We are only using the morphologic descriptors of MRI to report contrast enhanced mammography. And at the end, the information of both BI-RAD mammography and BI-RAD MRI should be combined in a same or in a single report with the common recommendations. Okay, and any abnormality identified in low energy, it should be correlated with the combined image and vice versa. And if incidental enhancement are identified on recombined image, but has no correlate in identified in the low energy image, then we have to proceed to perform ultrasound or MRI, and in the interpretation of low energy and recombined image should be included in the image report, and management decision should be made based on both sets of image. Okay, so can you tell me about these two images? What is this and what is this? Is it clear now?
Yeah.
This is what?
This is digital at the right.
This is contrast enhanced spectral mammography.
The left one.
And what does this represent? Here you can see contrast spectral mammography. So
This is low.
On the left side, it is low energy, and on the right side, recombined
excellent. This is low energy and recombined energy. Low energy demonstrate area of
architecture distortion.
Is architectural distortion and asymmetry.
Asymmetry.
If you look here, and the same area here, it is asymmetry compared to
also.
Yes.
But there is a distortion and asymmetry, or asymmetric distortion, and the recombined image demonstrate what?
And irregular enhancing mass lesion at the upper outer quadrant.
In the same locations of low energy image, okay, there are multifocal
with
enhancement.
multiple, yes, with
Multifocal
multiple,
enhancement, heterogeneous enhancement. You see, I need to see the other view to complete the picture, but at least there are multifocal. At least this is multifocal malignancy. Yes.
About this, low energy, it is similar to digital. How can I differentiate?
Huh?
The low energy.
the title is contrast enhanced spectral mammography.
It's
So
no title.
Yes,
the
I said
no
protocol,
title.
to you, I told you that this is contrast enhanced spectral mammography. Tell me what are these?
I'm talking about if I have no title.
Yeah, no title, no. Yes,
Yeah,
because
yeah.
because we said
So,
the low energy
okay.
this represent the regular mammogram, but you will take
Yes.
it
Okay.
during
Okay.
spectral mammography. It is
Yes.
it's a
Okay.
mammogram. It has the same criteria of the full-field
digital.
digital mammography, and
Okay.
it represents and reported in the same way.
Okay.
But it is part of anybody has idea. So the mammography, you know the mammography, and we'll go in the next lecture and next lecture talking about how to report mammography. But now let us go for to have the breast MRI lexicons to apply it for the contrast enhanced mammography. Do you have any idea about the lexicons of MRI? We said the kinetics is non-applicable because this is not a dynamic study. It is one-time contrast study. So it is just we can use only the morphologic criteria or morphologic descriptors to evaluate the contrast enhanced mammography. Okay. Any of you remember the lexicons?
about MRI, and also about also in MRI, the pattern of enhancement. You have to apply it in the mammogram. So you can describe
what
it
what are the morphologic descriptors?
Focus.
Excellent. A focus,
Focus, mass, and non-mass like enhancement.
Excellent, well done. What is a focus?
Focus, it is small, less than 2 millimeter.
Not too small.
It's too small, 5 millimeter, sorry.
5 millimeter, excellent. So the morphologic descriptors, same as for MRI. Enhancing, starting by enhancing focus, which is the enhancing dot, less than 5 millimeter. It is too small to be further characterized with morphologic features or to apply further morphologic features. But also, we don't know about these two to evaluate the focus. Is it benign or malignant descriptors? So it has criteria. Certain depend on certain criteria to say, is it a benign or malignant? Which criteria? Do you know? Here, this is single faint in a case of adenosis. This is single but intense in a case of invasive cancer. These are multiple foci, but are faint in a case of adenosis. These are multiple bilateral, but are asymmetric and intense in a case of mixed invasive lobular carcinoma and ductal carcinoma. So it depends on the focus. Is a focus is less than 5 millimeter. But if it is faintly enhanced or intensely enhanced, if it is single or multiple, if it is new, if it is enlarging, if it is whatever, there are criteria depend on. Generally, if it is multiple, bilateral, symmetrical, faint, these criteria are really going with benign descriptor. But if it is single, if it is intense, If it is unilateral, if it is asymmetric, then this is a malignant descriptors, or at least we'll say it's suspicious. Okay, so there are exceptions. Multiple bilateral intensely enhancing foci should not be included as a normal background parenchymal enhancement or hormonal changes unless proven by biopsy. Then we'll shift to enhancing mass. When we talk about morphologic criteria on MRI or in contrast enhanced mammography, so we are talking about the enhancement, either enhancing focus, enhancing mass, or non-mass like enhancement. We finish the focus, enhancing mass, then we'll characterize it further by morphology, by the shape pattern, margins, and so forth, enhancement characteristics, and so forth. Regarding the shape, it is same as other modality. Regular shape over rounded is benign descriptor, and irregular is malignant descriptors. The margins, if it is circumscribed, it's usually, with few exceptions, it is a benign descriptors. If the margins are not circumscribed, related to the MRI and contrast enhancement, the only descriptor unique to the margin descriptor unique to the contrast study is irregular margin. You see, generally we are not using irregular margin. Irregular margin used for the contrast study. If it is not circumscribed but not speculated, we call it is irregular. If it is microlobulated, if it is angulated or whatever, we just say it as irregular. Is it clear? Either speculated or irregular. This is non-circumscribed, which both are malignant descriptors. Going to enhancing, internal enhancement characters, if it is homogeneous, generally is benign with exceptions, and dark internal septation characteristic of fibroadenoma also benign. And if it is heterogeneous, it is malignant descriptors. And there is also rim enhancement, but here they make it as an exception, the ring enhancement. And they said we have to correlate it with ultrasound to make sure is it a cyst, inflammatory cyst, or is it a soft tissue, or so forth. Okay, going to non-mass-like enhancement. Non-mass-like enhancement, first of all, we are looking, is it symmetrical or asymmetrical? If it is non-symmetrical enhancement, as in this case, so this is a malignant descriptors. In this case, it is bilateral intense in case of malignancy. But in this case, when we look here, this is irregular, intensely enhancing mass with enhancing adenopathy in a case of suspicious or in a case of breast cancer, but there is bilateral, almost symmetrical, okay, foci of enhancement. In this case, the patient was young and the study performed near to her menstruation. So make it challenging. Is it due hormonal effect and physiological enhancement related to cyclic hormonal effect, or this is intensive or extensive bilateral cancer, and they recommend to repeat the study in appropriate time to make sure. Going further, the distribution. Okay, we look for the distribution. It's more or less similar to the distribution of calcifications: focal, linear, segmental, regional, multiple regional, and diffuse. Except for regional and multiple regional, this is benign descriptor. All these are malignant descriptors. And then we'll go for the internal enhancement. Okay. Looking for the internal enhancement. Is it homogeneous or heterogeneous? Enhancement or clump or ring or cluster of ring. And these all are malignant descriptor except for homogeneous, although this homogeneous enhancement represent the case of invasive cancer. There is also exceptions. So what are the current applications of contrast enhancement? I'm still asking, do you like to continue the lectures or you want to stop here and continue another time? I think the two new topics are heavy, the tomosynthesis and contrast. I think I don't know what can I say. What is your suggestion? I have no problem. If you like, I can continue. If you want to just take more practice, more cases later, no problem. If you like to stop, you feel that it is too much information, it is up to you.
Interested lecture.
Okay.
Interested lecture.
Okay.
But
I have
if there is the cases, it is good, but more new information is difficult. But if you have cases,
so we can continue, and later we can more examples related to these cases. Case discussion. We can make a case discussion. Okay. Okay. So the current application of mammography fusion enhanced by contrast is it is primarily used in diagnostic settings and is helpful in problem solving equivocal cases, and can be used for preoperative staging of breast cancer, monitor response to neoadjuvant, and it also can be used as alternative to breast MRI in case of high risk screening adjuvant to mammography. Okay, if you look for this, definitely extremely dense, this screening mammogram demonstrated extremely dense mammography, which in a patient having family history, and clinically she has no negative, and this mammography is negative for breast cancer. Doing ultrasound demonstrates suspicion both in her right breast as well as axilla, and doing contrast study demonstrate a unifocal cancer, enhancing cancer and enhancing that lymph node to be proven to be invasive ductal carcinoma. Again, this is screening high dense, extremely dense mammography, okay, but having has no a 55-year-old, but has no family history, and her ultrasound demonstrates here in mammography, with the exception of this suspicious lymph node, there is no other suspicious findings, but ultrasound demonstrate a high buccal suspicious mass on the left breast. Okay, on view of this suspicious finding, proceed to contrast enhanced mammography, demonstrate enhancement of this axillary lymph node, and the enhancing mass seen on ultrasound is also be visualized on the CC view, as well as small enhancing mass in the right CC, which was not well seen on MLO, but at the same time the left breast mass becoming fainter. So they suggest that because of rapid washout, they perform the CC first and then the MLO. So because of rapid washout, this is small lesion could not be appreciated, and this is become less, and at the end, both of which proven to be invasive ductal carcinoma, the right grade 1 and the left grade 3. So regarding the screening high-risk women. As you know, MRI is used to screen high-risk patients, more than 20% lifetime, adjunctive to mammography, but also can be helpful in supplementary screening of intermediate risk between 15 to 20. But at the end, if we collect all these women need ultrasound, need MRI screening, even if they use abbreviated MRI, it will be a large number. So they can use, instead of MRI, screening mammography as alternative to MRI to screen those group of people, and they may provide additional vascular capacity to better screen also the intermediate risk, since it has a comparable effect to or accuracy to breast MRI. Extensive data demonstrate that contrast enhancement may improve sensitivity and specificity when compared to the digital mammography alone or to the digital mammography plus ultrasound, in particularly in patients with a dense breast. So it can be useful to be used as a screening adjunctive tools. And also it is helpful to evaluate findings, equivocal findings detected on screening mammography, as in this case, single view asymmetry, when contrast study performed demonstrate no abnormal enhancement. So expected to be no cancer, but because it was small, they give it Birat-3 and followed for 4 years, but there was no cancer. Can you tell me what is going on in this case? Any volunteers? What is the difference between these?
The right is digital mammo, the left is contrast.
Excellent. Who's
There is a
talking?
lesion. Sarah Osman.
Sarah, mashallah, how are you?
Alhamdulillah.
Yes, this is contrast. And what is going on? What is abnormal? Any abnormality?
Abnormal, yeah, there is a lesion.
Where? Which side?
In the middle of the breast.
Which side? Right or left?
Right.
Right. Left is normal. It is asymmetric, but it is bilateral.
Yes, yes, yeah, yeah.
If we look for the low energy image or regular mammogram, we can say here the high density, there is high density asymmetry.
Bilaterally, yeah.
Okay, irregular asymmetries, both sides, more on the right side, associated with long speculations going toward the nipple with some thickening and going back to the posterior breast. And its same finding could be appreciated on
bilaterally.
Okay, before looking for the contrast study, based on this, what your differential diagnosis? Bilateral architectural distortion and speculated asymmetries. It could be complex sclerosing lesion like sclerosing adenosis or radial scar versus malignancy. How does the contrast study help us? It demonstrates what? This contrast. Expected the parenchyma to be subtracted completely. So what we have seen here, this
bilateral lesions.
Bilateral intensely enhancing lesions. So generally, complex sclerosing lesions are not significantly enhanced. Because of this significant enhancement, it will upgrade the possibility. Yeah, so you see, that is mostly, it will be cancer and it was proven to be extensive bilateral invasive ductal carcinoma grade 2. Interesting,
Okay.
yeah?
Yeah,
So
very
sad.
interesting.
Yeah. This case here, we have area of architectural distortion, very subtle architectural distortion.
Yes.
The breast is dense. Doing contrast demonstrate what? Indistinct, okay? Or intensely enhancing mass with irregular or speculated even margin proven to be grade 1 invasive carcinoma. So the data suggests that absence of enhancement associated with architectural distortion with minimal background enhancement is strong indications of benignity. If you have architectural distortion and contrast study demonstrate no enhancement, that means strong
Benign.
architectural distortion is due to benign cause.
Process.
So also in problem solving, contrast enhancement is helpful in equivocal or inconclusive finding detected at conventional imaging examination, and study reports that high sensitivity for delineation of malignant findings, particularly masses distortion or calcification in patients having recall from screening. And in this case here, we have calcifications, pleomorphic calcification in segmental distribution associated with asymmetry, but no underlying mass. Ultrasound was not impressive, but look for the contrast enhancement, demonstrate irregular
Large mass.
enhancing mass with irregular margin in a case of invasive ductal carcinoma. So in assessment of calcifications, as you know, commonly recall after screening because of microcalcification and are well depicted on contrast enhancement. Either the morphology of microcalcification in low energy image like regular mammography, or the associated enhancement in recombined image. The associated enhancement significantly higher in malignant lesion, up to 90.1%. And there is good correlations between a cancer size and postoperative histology. Contrast enhancement only minimally improve sensitivity of mammography from 91 to 94, because already calcifications can be picked on regular mammography. And some invasive cancer like lobular and some DCIS might not show enhancement at malignancy. So overall, studies suggest that the presence of enhancement on imaging suggests malignancy, but absence of enhancement cannot exclude it. And therefore, as with MRI, suspicious calcification at mammography should be biopsied whether or not they show enhancement. If morphologically suspicious, but on contrast enhanced or on MRI doesn't show enhancement, you have to proceed and to biopsy that calcification. Is it clear? In this, let us go for symptomatic patients. So what about the symptoms or symptomatic woman in the breast? What is the definition of symptomatic woman? If she has palpable abnormality, if she has palpable abnormality, if she has nipple discharge or non-cyclic localized pain, okay, non-cyclic localized pain, nipple discharge or palpable abnormality, these are the significant breast symptoms considered to be symptomatic. This is a 50-year-old lady presented with a palpable left breast lump. Here there is just area of asymmetry, okay? Ultrasound, area of heterogeneity of non-mass like parenchymal lesions, but contrast enhancement demonstrate multifocal areas of non-mass heterogeneous enhancement proven to be grade 2 invasive lobular carcinoma. So again, this is 60-year-old lady having palpable abnormality of left breast, MRI mammography, screening mammography or diagnostic mammography demonstrate high density and non-circumscribed mass, oval mass here. On ultrasound, it looks like a cyst. It is an echo-free, but it's indistinct, and there is a lot of reactions, surrounding reactions. That is why, okay, they proceed for contrast-enhanced mammography. Can you see the mass? It is not a cyst. It demonstrates heterogeneous enhancement and irregular margin. And another enhancing lesion is seen in adjacent to that one, was proven to be a malignancy. So the definition of symptomatic breast is varied, and the symptoms include palpable mass, localized pain, non-cyclic, and nipple discharge, and contrast enhancement is promising in this setting, and the sensitivity and accuracy of mammography dramatically improve with contrast enhancement, while the sensitivity of low energy serve as standard. Full-field digital mammography represent 84.4%. The sensitivity of entire contrast examination is for 94.5%. And for the diagnosis of palpable lesion in dense breast, the combined image can make the diagnostic power to be like that of combined use of mammography plus ultrasound. Okay, so let us go for another indications, which is preoperative assessment. If we look for this image, this is mammography, demonstrate something here, proven to be invasive cancer. Okay. But the breast is relatively or heterogeneously dense. Doing contrast enhanced mammography demonstrate same lesion enhancing on the right breast, but picked another smaller lesions, enhancing lesion in contralateral breast, which was also seen on MRI along with the enhancing right breast lesions. So again, contrast enhancement significantly better than full-field digital mammography in depicting index cancer and additional ipsilateral or contralateral. You look here, even for this, the same lesion itself is more appreciable than on full-field digital mammography, and further, it demonstrates an enhancement in the contralateral breast and in accuracy more or less or sensitivity equal to the MRI. So regarding actual index tumor size, as you know, the most sensitive regarding the actual tumor size is MRI. And now also they said the contrast enhancement having near result as MRI. And furthermore, contrast enhancement has superior positive predictive value for detected additional lesion. As we mentioned, not all lesions seen on MRI are cancer, and they have a lot of unnecessary biopsy, and the positive predictive value is relatively low. But the contrast enhancement is relatively more specific than MRI, and the lesions, where enhancing lesions on mammography are much more giving a positive results. And this is again here, a dense mammogram with large cancer on the right breast. Contrast enhancement intensely here demonstrate large but unifocal cancer in the right breast. However, again, demonstrate another cancer in the contralateral breast. So contrast enhancement used to accurately determine if the disease is unifocal, multifocal, multicentric, or bilateral, and it found to change the surgical management in up to 20%. Again, This is a preoperative assessment of 60-year-old lady having left previous surgery for breast-wide local excision or conservative breast surgery for breast cancer, presented with this dense mass here in the relatively dense mammogram. When doing contrast study, demonstrate another multifocal lesion in the same breast. However, in the contralateral breast, there was nothing or no abnormal enhancement proven by pathology to be a second multifocal cancer. While in this case, after contrast in enhancement mammogram in this dense breast, confirmed that the cancer seen on the right breast is a unifocal cancer. Okay, so in preoperative assessment of disease extent, the studies have shown that contrast enhancement demonstrate improved performance for evaluating disease extent compared to mammography and ultrasound. And dense breast has a higher incidence rate of multicentric, multifocal, and contralateral lesions that may be missed in conventional mammography and can usually be seen in combined image of the contrast enhanced mammography, double energy contrast enhanced mammography. Yani, the dense breast not only obscuring, but it has chance of developing more cancer. You expect in a dense breast to find additional cancer, to find it is liable to have multifocal, multicentric, and contralateral cancer. However, contrast enhancement can be alternative to breast MRI and has the added benefit of being able to detect microcalcification due to the presence of low energy images, which is not possible with MRI, and also overcome the MRI limitation of high cost, limited availability, false positive findings of MRIs that can lead to additional biopsies and anxiety and mastectomy. Although contrast enhanced does not enable evaluation of the axilla or other nodal group. Going to another indication, which is response monitoring using contrast enhanced mammography. Can you tell me the difference between these image? Monitoring the response of chemotherapy effect. Mm-hmm.
Large enhancing mass at the right breast, decrease in the second follow-up contrast mammogram, and fade away at the side of the clip. At the site of the clips.
Excellent. Well done. Excellent. Excellent. Okay. Okay. So I don't know what's happening. Right. This 3-centimeter invasive cancer. Okay. This is during the mid cycles or the mid treatment. Okay. Demonstrates significant improvement, and this is after completion, demonstrate almost complete disappearance, and this is represent complete radiological response, which was proven to be complete pathological response in post-surgical specimens. And the study found that contrast enhancement mammogram was superior to MRI in prediction of pathological complete response in some studies. Again, this is another breast cancer, okay? After 6 cycles of chemotherapy, demonstrate almost lack of any enhancement, only the clip in the place, same result seen on MRI here, and pathology revealed complete pathological response of post-surgical specimen. So in the assessment of neoadjuvant chemotherapy response, as you know, MRI is superior to physical examination, mammography, ultrasound, while the new data or the early data suggests that contrast enhancement has a comparable result and can be alternative to breast MRI. Based on the same principle in contrast enhanced mammography image, the absence of enhancement at previous tumor site will be reassuring. And accurate delineations of disease extent is critical in planning conservative. So the baseline is essential. You have to have a baseline, then to follow. And additionally, the presence of low energy image replace and obviate the need for the additional fulfilled digital mammography examination so that the patient need only one appointment after therapy. So going for assessment of post-operative changes, if you compare this, when we look here, definitely this is the site of surgery. But based on this complex parenchyma, extremely dense mammogram, definitely we could not exclude any recurrence. But based on this mammogram and lack of contrast enhancement, definitely is reassuring and revealed no recurrence. Again, this patient having breast conservative therapy for breast cancer. She's 64 and presented with this palpable abnormality. Ultrasound demonstrate a complex cystic lesions with posterior enhancement, but very thick wall. Okay, here there is just an architectural distortion at the site of surgery. But looking for post contrast, definitely there is no any enhancement which is reassuring. So when aspirating this cyst, it was a hemorrhagic fluid, and after surgery there was no residual malignant cells. Another case of post-surgery, okay, having a flap here, okay. This is left MRM with a flap, developed dystrophic calcifications, and ultrasound demonstrate these multiple atypical cysts. There is no posterior enhancement and are thick walls. So based on that, they proceed for contrast study, which revealed no any type of enhancement, and both contrast revealed, both surgery revealed oil cyst in dystrophic calcifications. So this is a fat necrosis. Another patient, look here, she has both surgery on the left breast. At the site of scarring, there is this speculated mass. Both contrast demonstrate no any type of enhancement, and there is no enhancement in the contralateral breast. This is the area of irregular hypoechoic speculated mass on ultrasound corresponding to mammography. Aspirations reveals no residual cancer. Again, this is a lady having left breast cancer or therapy, and at site of scar, this is speculated mass. And this is the ultrasound at site of scarring, the speculated mass, but by doing contrast study, reveal no enhancement at this site of this scar, but there is incidental enhancing lesion in suprarenal region. Going back, you can see here area of asymmetry on the low energy image, and proven to be this area, no evidence of malignancy, but that one was proven to be recurrent invasive carcinoma. So post-operative changes, the scar tissue after surgery appear as architectural distortion on the standard mammography, resemble definitely the recurrence, and is difficult to be, it is challenging and difficult to differentiate, especially in dense breast. And as on MRI, lack of enhancement is reassuring and exclude tumor recurrence. And because usually the tissue scar is minimally or not enhancing compared to the enhancement of tumor recurrence. Contrast enhancement can be alternative to MRI, although it does not enable evaluation of the axilla or other nodal regional group. So let us go to diagnostic performance of contrast enhancement. As we said, it is superior to the standard mammography and ultrasound, and it's useful in identification of lesion in a dense breast, satisfactory for inconclusive lesions or equivocal lesions, detection of occult lesions, and shown considerable promise in therapy monitoring, and can be considered as a good alternative for women who are unable or unwilling to undergo breast MRI. And compared to breast MRI contrast enhancement, mammography showed comparable diagnostic performance and probably is likely more specific than MRI and more accessible, more cheap, more comfortable, less noisy, having shorter examination time. Compare 5 minutes of contrast enhancement mammography versus 30 to 40 minutes of breast MRI. And thus, preliminary data on the use of contrast enhancement in the screening setting are promising and can be used as alternative in to MRI as adjunct to mammography. Adjunct screening tool to the mammography. Like other technique, definitely having a limitations, including the risk related to iodinated contrast agent like hypersensitivity, renal insufficiency, or the challenges of evaluation of equivocal mammographic findings. Some of the benign lesions like fibroadenoma, hyperplasia, or papilloma can be enhanced, or ring enhancement of inflammatory cyst. Also, the false negative findings by a limited field of view and lesion location. If the lesion in extreme posterior medial breast might not be included in the field of view, and on fulfilled digital mammography, lesion cannot be visualized if it is close to the chest wall and so forth. And contrast enhancement does not enable evaluation of the axilla and local nodal regions. Also, some of the lesions can be overlooked because of their nature, like mucinous cancer might not be enhanced, or some types of lobular carcinoma and non-calcified BCIS. We said non-calcified because it might not, if it is not calcified, will not be seen in low energy image, and it might not be enhanced, also will not be seen in recombined image, also can be missed and give positive, false negative results, and might be overlooked also on MRI. Artifacts, there are two types of artifacts, same as fulfilled digital mammography, and artifact related to the contrast, materials, and radiation exposures, generally slightly more, but still falls within the mammography quality standard guidelines, is not more. and the study limitations. Scientific evidence on the use of contrast in study is still on limited base study. We have seen this image before, and definitely this one of the challenging and limitation of the contrast study when we see this ring enhancement, looking for the mammography to see opacity. We don't know if it is a soft tissue or if it is a soft tissue or a cyst. We need to correlate it with ultrasound. So in the assessment of inconclusive or equivocal findings, problem solving, several issues we have to be considered, and we have to look for the low energy images, and we have to know that the cyst, it has to be thin walled or enhancing rim or negative enhancing lesions, and we have to consider the thicker enhancing wall of inflammatory cyst. This is examples of enhancing benign lesion in a case of enhanced skin hemangioma. You can see it here in tangential view. It is at the level of skin. This intense enhancement here, asymmetrical on one side, was proven to be due to fat necrosis, but definitely the appearance is malignant descriptors, non-mass-like enhancement. Again, a non-mass-like enhancement here, and this is enhancing mass. In a case of granulomatous mastitis, this can be limitations. And this case here, the mammogram demonstrate popcorn calcification and a small area or a small group of round microcalcification in the left breast. Doing ultrasound demonstrate all these small, tiny, irregular masses. Look how we might not consider these tiny lesions, and especially after contrast study, there is only faint, very soft enhancement. So when they biopsy these tiny lesions, it was 3 invasive ductal carcinoma moderately differentiated. So in this case, this is a false negative results. So in the evolution of radiographic breast imaging in 1930, direct exposure film mammography started with a cancer detection accuracy was 93%, and followed by zero radiography in 1970, 72 screen film mammography improved the detection or the accuracy of mammography, and more evolutions. And at 1992, along with these technology advances, ACR developed BIRAT for mammography interpretation, and a big evolutions was appeared at 2000 due to full digital mammography used up to date. And 2011, both breast tomosynthesis and contrast enhanced digital mammography era seen. Okay, so the mammographic breast density. Women with extensive density are doubly disadvantaged. As you know, the high breast density significantly reduces the breast sensitivity by unmasking the, it has a masking effect of detection, breast cancer detection, but at the same time, it has a higher risk of developing breast cancer. It's strongly associated with increased breast cancer. So mammographic breast density is rapidly becoming a hot topic in the medical literature. And the dense breasts are not only susceptible to primary malignancy, but also increase second cancer in the ipsilateral and contralateral. So if you look for high density mammogram, you expect to find, you will be afraid to find not only a unifocal cancer, but afraid to find multifocal, multicentric, or bilateral breast cancer. So an understanding of context, scientific evidence, and controversy surrounding the topic of breast density as risk for breast cancer is crucial for radiologists that can respond accurately to questions from patients as well as from the referring clinicians. And high breast density is an independent breast cancer risk, as we mentioned, factors, and dense breast and could be assessed qualitatively by assessment of parenchymal pattern or qualitatively by calculating percent of breast density. Consequently, many US states now have a law requiring that women with dense breast be notified after a mammogram so that they can choose to undergo supplementary screening tests to improve cancer detection. And consequently, many US states have laws requiring, sorry, we mentioned it. We have mentioned it. Okay. So in clinical practice, breast density assessed usually in two views as virtual. As you know, we use the virtual to assess breast density, but definitely this virtual assessment, it has a limitation. So now they use artificial intelligence to evaluate and to give computed analysis, and it will be give an accurate artificial intelligence tools to accurately and consistently classifying the breast densities. These are here qualitative and quantitative type of measurements of breast density volumetrics. Okay, so at the end, we can conclude that radiographic breast imaging has been numerous technological advances since early days of direct exposure, film mammography, and the evolution has been rapidly and substantially during several decades to include several other advances, technologies that aid in the detection and diagnosis of breast cancer. This evolving technologies comes the evolving role of the imaging radiologist. In the past, the radiologist merely interpreted images and provide report to referring physicians. But today's the breast imaging radiologist plays an integral part of multidisciplinary team caring for the patient with breast cancer. They have more tools as additional technologies achieved. Breast imaging radiology continue to advance their expertise, and the implementation of tomosynthesis has increased breast cancer detections and decreased the number of recall from false positive finding at screening, contributing to improve specificity to a diagnostic evaluation. And the fulfilled digital mammography and as well as tomosynthesis both rely on anatomic changes only and caused by the breast cancer. However, contrast enhanced mammography demonstrate anatomic or morphologic as well as breast vascularization effect in recombined image. And the contrast enhanced mammography as an imaging breast modality serve a cost-effective alternative to breast MRI in some clinical setting, and a major clinical indication for the dual energy. MRI could be the use as a problem-solving modality in case of equivocal mammographic and ultrasonic findings. Thank you very much. I hope you are not sleeping.
دسمة.
Yes.
صحيح.
Still good. I thought you are sleeping.
شكرا جزيلا دكتورة رباب شرفنا ثقافة جميلة جدا. شكرا.
نهلة.
recording يا سارة.
welcome نهلة جعفر.
الله يسلمك.
شرفتينا.
الله يبارك فيك. شكرا على المحاضرة الشيقة والمليئة بالمعلومات.
والله يعني with pleasure زي ما قالوا.
هاي يا بص هنوقف الريكوردينج على هنا وبعدين
But if there are any questions, no problem. If there are questions, you can continue asking questions, then we can stop.
تمام.
Any question?
The big problem in contrast in
السلام عليكم دكتور رباب، كيف الحال؟
وعليكم السلام والرحمة دكتور معاوية.
إن شاء الله كويسين.
الحمد لله. You are welcome.
أتمنى الجميع يكون بخير.
شرف عظيم، شرف عظيم لنا حضوركم. أنت ونهلة
الله يبارك فيك. والله مشكورة على مجهوداتك العظيمة وتحياتي للجميع، ونتمنى الناس تاني تتلمى في الخرطوم بعد السلام إن شاء الله يعني.
يا رب يا رب. والله نتمنى. فبجد يعني أنا قصدت إنه يعني to update ourselves بإنه الناس واقفة وين يعني. فزي ما قلت في الجروب إنه these يعني advances before the يعني it was at least الtomosynthesis والcontrast enhanced mammography يعني started for about 11 or 12 years by now. But if we look around يعني في يعني حولنا في الدول اللي حولنا it's almost all they have these techniques. يعني لو جيت هنا مصر they have since long time. السعودية فيها، الخليج الآن عندهم شغالين بيه regular. الأردن يعني ما بنتكلم على نطاق يوروب ولا بنتكلم على نطاق US، نتكلم على النطاق الإقليمي. وبعدين أنا جبت برضو I've started my talk بالcomparative comparison between the digital والanalog, because still we have some people that are looking to bring an analog system يعني in spite of useless low quality image, but I don't know how they are thinking.
بالمناسبة أنا كان تواصلت مع وزارة الصحة الاتحادية الشؤون الهندسية ولا اسمها شنو هي المسؤولين من الأجهزة الطبية دي.
أيوة.
ووريته إنه يعني تمنعوا لنا قصة أنالوج وكده، دي ما تيجي خاشة البلد. حكاية لازم تكون فول فيلد ديجيتال ماموجرافي، وهو متعاون. وحتى يعني أخذت الحاجة دي في السبيسيفيكيشن بتاعته، كانوا خاتيننا وكده يعني. ف يعني المفروض باي ناو تاني ما في حاجة انالوج ولا سيمي ديجيتال ذاته تخش، لازم كلها فول فيلد ديجيتال ماموجرافي يعني.
والله نحن ما المشكلة lack of system يا دكتور معاوية. the lack of system. إحنا شكلنا هنخش في السياسة. We can stop recording يا دكتورة سارة.
يا بس انت بالهوست الا تقفل الريكوردينج من عندك.
طيب اقفله انا.
انتهيت البار تحت
اعمل
تقول ستوب ريكوردينج.
ستوب. طيب. Are you sure you want to stop recording?